is a patient who is a 60-year-old male with no significant past medical history present to your clinic for initial evaluation. He has not been feeling well for the past few months and has noticed increased shortness of breath on minimal exertion, increasing abdominal girth and pedal edema. He also reports easy bruising for the past 3 weeks with decreasing urine output. BP is 170, heart rate is 90. On physical examination, he has elevated jugular venous pressure with bibasilar crackles and pitting pedal edema. You don't appreciate any cardiac murmurs or added heart sounds. Blood work is significant for elevated creatinine. And they're asking which are the following you will do to confirm the diagnosis. First of all, this is a patient who's coming with a biventricular failure. This patient is having features of both right heart failure as well as left heart failure. Plus, at the same time, this patient is having elevated serum creatinine, and this patient is developing frequent bruises as well. And ECG is significant for extreme low voltage complexes. You all know the definition of low voltage complexes. In the limb leads, if the QRS amplitudes are less than 5 millimeter, or in the precordial leads, if the QRS amplitude are less than 10 millimeter, you're going to call it as low voltage complexes. And what are the differential diagnosis of low voltage complexes? It can be COPD, severe obesity, or pericardial effusions with or without tamponade, or probably you can see in severe heart failure and severe dilated cardiomyopathy rarely. But more important, you will be able to see low voltage complex in restrictive cardiomyopathy. It's a very, very important differential diagnosis. Here is a patient who fits perfectly in the diagnosis of restrictive cardiomyopathy. Why? Because RCM can come with biventricular failure, RCM especially because of amyloidosis, especially AL type of amyloidosis, can result in increased serum creatinine as well as bruising, which is called as amyloid purpura, right? So here I'm going to make a diagnosis of AL type of amyloidosis causing restrictive cardiomyopathy. Remember, amyloid heart is very, very important for exams. So one of the important cause of restrictive cardiomyopathy. And what will be the characteristic examiner's description of amyloidosis in exam? So in the ECG, you will see extreme low voltage complexes, but in the echocardiogram, you will be seeing thick ventricles. This is a kind of a paradox. You see thick ventricles in echo, but in ECG, you will see low voltage complexes. And why echo is showing thick ventricles? That is because of the deposition of amyloid into the myocardium. And this amyloid in the echocardiogram can appear as sparkling bodies. It's called a sparkling appearance. It's another clue. And apart from that, the typical area where amyloid tends to get deposited in the ventricles is going to be in the basal portion of the interventricular septum. Characteristic area where amyloid tends to get deposited. There will be thickening of interventricular septum in the basal area especially. So these are the clues for diagnosing amyloidosis with regards to cardiac amyloidosis, especially in the exams. And why I'm specifically talking about AL type of amyloidosis. Remember, AL and transthyretin amyloid both can involve the heart, but TTR related amyloid will not be involving the kidneys, and they have nothing to do with the bruises and purpura. So that's the reason I'm going to diagnose AL type of amyloidosis here, which will be usually due to some background multiple myeloma, which can involve the heart, which can involve the kidneys, which can cause hepatosplenomegaly, which can cause macroglossia, it can cause GA involvement, and so many things. It can cause peripheral neuropathy, especially autonomic neuropathy, and so many things can happen with AL amyloidosis. So here I'm suspecting AL amyloidosis causing restrictive cardiomyopathy. So what I'm going to do to confirm the diagnosis? Remember, there are two investigations that can confirm the diagnosis. One is cardiac biopsy and second one is abdominal fat pad biopsy. But I would like to go for abdominal fat pad biopsy first because it's less invasive. So endomyocardial biopsies can of course diagnose amyloidosis here, but it can be avoided because it's very, very invasive. And you can go for less invasive options like abdominal fat pad biopsy first. Then if it's not yielding and still you suspect amyloidosis related RCM, then probably you can go for cardiac biopsy. The right answer for this question is going to be option number C. Cardiac cath, maybe to differentiate between constriction and restriction in difficult cases, you can do it, but apart from that, echo itself can tell you the difference between constriction and restriction, so I don't think you need them in the current era. And apart from that, renal ultrasound can show kind of bulky kidneys, but that's not going to make a diagnosis of amyloidosis. Remember, there are some important differential diagnoses for normal or enlarged kidneys in the presence of CKD. The most important DDs are ADPKD, amyloidosis, FSGS, HIV. But can show you kind of bulky or even enlarged kidneys despite having CKD, but that's not going to definitely tell you that you're dealing with RCM and L type of amyloidosis. So the right answer for this question is going to be option number C. If this is unyielding, then probably you can go for endomyocardial biopsies.